Okay.
Hi, I'm here today with Lisa Hutchinson, and I'm Katherine. And yes, Lisa, I'm just going to be talking to Lisa about some the subject beginning with a P, propaganda today.
Thanks very much for that lovely introduction, Catherine. So I think I can talk a little bit about another P, which is publishing,
Hmm.
that links with propaganda because that's my background. So I did my first degree in biochemistry at UCL in London, and then straight after that went on and did a PhD at the Institute of Cancer Research. It was quite a preclinical PhD. So it was looking at cell signaling in mouse fibroblasts, but relating to breast cancer. And after I'd done that PhD, probably finished in my mid-20s, I wanted to not stay in academia in terms of being a bench scientist, but still wanted to use my science background. So I thought, what can I do? So I thought, oh, I'll go into publishing. And so for 2 to 3 years, I worked for a breast cancer journal based up in London called Current Science Limited. It was a publisher that published lots of different biomedical sort of journals. Then I had a small stint after that working for a medical communications agency, where we're the sort of middlemen between what big pharma do and then what finally gets put into the sort of what you might call it medical or academic literature. And that was insightful. And then between 2004 to 2017, for 14 years, I was the chief editor of a Nature journal called Nature Reviews Clinical Oncology. So my background is
Did you say
17 plus years.
nature of
Yeah,
nature
yeah.
of something?
The journal I was the chief editor of was called Nature Reviews Clinical Oncology, rather long-winded title. So it was one of their review journals, and they launched 8 of them in the clinical sciences. And the one that I was editor of was the oncology one because of my
Hmm.
cancer background. So, but what I started to notice when I was working in that role, back sort of around 2010, 2012, was that the sort of pharmaceutical industry kept coming out with all these big trials in New England Journal of Medicine, in the Lancet, in the Journal of Clinical Oncology, all the top cancer journals and medical journals. And they were talking about game changers and sort of, breakthrough, sort of fantastic new drugs. But when you delved into the actual data, they were nowhere near as striking or as amazing as they were purporting to be.
Hmm.
In fact, if anything, there were quite severely adverse events associated with some of these drugs, and they were literally 2, 3, 4 week overall, or even progression-free survival advantages. So I started to become a little bit more skeptical, should we say, about some of the allopathic medicine that was being done in oncology, and I left in 2017, and I've been a kind of freelance editor since then. But you talked about propaganda. So how does that link in with publishing? And that's because really what I've noticed in the last few years, but particularly since COVID, has been that there has actually been a cleverly orchestrated mechanism in play that has enabled certain research to be very favourably publicised in the public arena, whereas other research completely and utterly decimated, or censored, or not out there in the wider literature, or it's been sort of discredited for whatever reason, even if the science is actually quite good. And so you've got two sort of extremes going on. We've got the pushing of a particular narrative or series of research results that all often connect up to the same funding
Hmm.
mechanism. They often have the same people funding that, or the large corporate institutions that are doing that. Whereas more independent research that perhaps is not industry financed, shall we say, that research often doesn't see the light of day, or is given a very sort of low profile, should we say. And that, when we have a situation, Catherine, where science in particular is being lauded upon by certain sort of people that are high in the public eye as being the science to follow, and that no one else should be having a different opinion to what the mainstream view is, well, in my opinion, we don't really have science, because the whole point about science is it's never a done deal. It's continually evolving, and we constantly have to be assessing and debating and critiquing, not in a negative way. It can be done constructively and perfectly, amiably, but good science is done, it should be done on the, foundations of having a very strong ability to be able to raise concerns, raise debates, discuss these things openly in the scientific academic literature, and even in public debate forum styles or in the media. And that just blatantly is not happening. In fact, it's almost been completely cut off and sort of, should we say, atrophied since 2020 onwards, I would say. And we know
It
what
has. It
2020
has
onwards, don't
been
we? Yeah.
deafening in its silence, hasn't it? The debate. So that's very, very interesting what you've just said. And, fascinating career that you've had. And, so many people's lives are touched by cancer. And you having actually worked in a practical way with cancer, with the cancer cells, and then being involved in being the chief editor for this oncology journal. You sort of got both ends of the spectrum, really, haven't you?
Yeah, it's really interesting, because we could have a massively long interview about this, but basically that I think a lot of science is, or scientific, there are scientists working in the academic arena, in the massive broad landscape, that actually don't recognize that censorship is happening right in front of their nose. They also haven't connected the dots about the fact that the funding mechanism of how their research is funded is also paid for by the same people that decide what gets published and what doesn't get published. And I've actually written an article in the one of the sort of more alternative newspapers. It's called The Light. A couple of years ago, around the summer of 2022, discussing how the academic literature has essentially been hijacked, and how that's enabled a sort of censorship or particularly focused narrative to occur. So I talk a bit about that in that article. But even I hadn't connected those dots until 2020. I'd started to be suspicious about what's going on in the publishing arena, what's enabling this censorship to occur. And I'm afraid to say a lot of these well-intentioned, big, very sort of high level, supposedly sort of altruistic, should we say, objectives that you hear about, things like sustainability, things like making everything open and transparent. So open access publishing is an example, where we hear that we have to be much more, careful about our environment and pollutions. And there are certain, sustainable development goals that a lot of big top companies and scientists are constantly referring to when they open up debates. I actually got an invitation from The Economist today to learn more. Yeah, now The Economist I don't sign up to particularly. It's just that back in the day when I was chief editor at Nature Review's Clinical Oncology, we used to go to lots of different conferences all over the place, in the UK as well as in Europe and America, Northern America, as well as Australia sometimes, and various other places. I've been to conferences in India as well, Middle East. So we did go all over the continents. And one of the ones that we went to back in 2015-16, not long before I left the company, was one that was in London that was held by The Economist about personalised medicine. And because I was on their mailing list, personalised medicine, which was all very popular, 5, 6, 7, still kind of is. Personalised medicine is all.
What does that mean, personalised?
Well, personalised medicine is supposed to mean, in the oncology world, it's meant to mean better treating patients and understanding what therapies to use according to their molecular mutational profiles of their tumours. In other words, because we know more about the sort of genetic makeup, if you like, of how a tumour gradually evolves and changes, and because we're able to understand some of the mutational and sort of chromosomal abnormalities that are occurring in the tumours, as well as the surrounding infrastructure of the tumour, in theory, we can even use sort of blood draws, they call them liquid biopsies, in order to determine in a slightly less invasive way whether a person's cancer, for example, might have progressed or whether it's stable. And so they coined this term personalized medicine actually back in 2010, I think, to highlight the fact that we were on the cusp of more genomic what they call, deep sequencing, or, rather sophisticated sort of multi-panel sequencing that allowed, in a short space of time, massive amounts of data to be gathered on patients' tumor profiles to then determine whether or not they had a particular subtype, a particular mutation that enabled them to be better treated on a particular therapy. That was the idea behind personalized medicine.
It's very interesting. And what you're saying there, because I practice naturopathy, detox, and homeopathy, as you know, and personalized treatment schedule wouldn't mean anything like that at all. If you came to see somebody like me, and then of course if you went to see somebody who practiced German new medicine, they would say that the tumor is actually quite a natural stage as in the process of the body's healing. And
Yeah.
so it's almost like we've got this view that in orthodox medicine they're sort of funneling you towards this particular end of drugs and chemo and radio and everything else. It may be personalized towards you, but actually the premise on which they're starting the whole treatment is not necessarily the one where we need to start. And I actually worked when my mother passed away from cancer when she was about 45 and I was 18. And I worked at that time had a job as a domestic and I often worked on an oncology ward. And my job was to do the cleaning and also to pour out the teas and the cocos and things like that for the patients. So I got to speak to quite a lot of different people. And I could see that they were sort of being starved of anything. They were lying in their hospital beds. I mean, most of them, when I came round, I was practically the only person they saw to talk to. And so the point that I'm making is that whole side of the care, it might have been personalized from the point of view of drugs, but it wasn't personalized from the point of view of what was going to help the spirits of these people to recover. It wasn't
Yeah,
going to
Katherine, I mean, you've hit the nail on the head. As far as I'm concerned, personalised medicine, it might be personalised to the tumour, but it certainly isn't personalised to the patient. They forget the patient in the
yeah.
whole of this. And not only that, but we don't actually have a good... I wrote a farewell editorial. It was called, I think it was something like Context, the Grey Matter of Cancer. And it was the final one that I wrote in 2017. And I basically said, we haven't even got a proper definition of the word cancer. We actually don't really know, even from a molecular point of view, what it is. I think it's often the body's detoxification mechanism. I think a lot of cancers are actually initiated through a trauma. In fact, Bruce Lipton, I'm a bit of a fan of him. I've become a fan of quite a lot of these more alternative naturopathic, people that talk about holistic, sort of holistic approaches to chronic diseases and how they have lots of common roots. They're nowhere near as singular as we might think they are. And actually, cancer, for me, I think has three main culprits, and I call them the three T's: toxins, trauma, and thought. You can literally think yourself ill. If you're in a toxic environment, you talked about in an earlier interview we did about the importance of diet, exercise, making sure you have things like yoga and meditation in a daily routine, good sleep quality, getting out there into nature and, having a walk in the park, really being among sort of the birds and the bees and the trees and everything like that. All of those things have a fundamental role in a healthy body. If we're getting toxins pumped into us through, should we say, aerosols that are coming through us from are being sprayed above us 30,000 feet, not to mention the fact that our water is nowhere near as health as it used to be. It's got a lot of heavy metals in it. And then we have foods that are often GMOs, genetic modified, not to mention loads of different things that are going on. So toxins play a big part. And I think with cancers, I've spoken to a few people who have had cancer, and invariably I say, did a traumatic event happen within 6 months to a year before your cancer, whether it's maybe a redundancy or losing your job, or was it something to do with a bereavement, or did you have a close relationship breakdown? Almost always there was a yes answer to those. So there's a link there with the 3 T's: trauma, toxins, and thought. I think the placebo effect brilliantly explains that if you actually think you're taking a medicine, even though if it's a sugar pill and you aren't, but the placebo arms in so many randomized controlled trials do just as well as the experimental arm. 90% of all cancer drugs fail completely in randomized phase 3 trials because they don't beat the placebo arm, and the placebo is a dummy drug. What does that
That's fantastic.
I mean, so I mean, that's just one area of the clinical trials that is interesting. But what we are finding is that the NHS, like you said, why doesn't it also offer all these other things? Doctors, I learned that doctors get 4 hours or not even 4 hours of immunotherapy training in their 5-year undergrad degree courses, barely a day, and they wouldn't know the difference between a T cell and dendritic cells pretty much if it hit them. I mean, that's a slight over exaggeration, but you see my point. They don't really understand the basis of good diet and understanding about physiology. I don't think anywhere near to the levels that perhaps they should do. That it's all geared towards drugs, profiteering. Even when drugs are off patent, if they aren't going to make a lot of money for the industry people, they often are completely overlooked as well. And it's very difficult for academics who haven't got industry sponsorship to use perfectly simple drugs that actually might have a role in cancer. Repurposing, drugs that might be used in propranolol, could be used in, for heart pressure. Actually, some of those drugs are not necessarily as futile, and they could have a potential role in certain cancers in certain settings, but they never ever make the light of day, hardly, because there isn't enough interest in doing trials for drugs if they aren't making money for the big players in the field, should we say. So
that really does, turn it around. I mean, it
does.
turns everything sort of round on its head, doesn't it? That the money making aspect of it, the gravy train, is more important than the health of the person who's being worked with.
Yeah, it is. And in fact, what you said earlier, just about, you were making the teas for the patients on the wards, and sometimes that was the only chat they had. And I do think that, from what I've seen, I think there are really well-intentioned oncologists there. They do try their best to give the best information they can and the best risk-benefit ratio. And, if the patient says to them, "Doctor, what do you think I should do?" I don't think that they are all heartless people, or that they're not I do think they're well-intentioned, a lot of them, but they don't have the training in almost looking at the patient from there's a patient behind this disease. What's their background? Have they got a family or friend infrastructure that can mean that they can go and get chemotherapy for the next 6 weeks every day, or radiotherapy, or for months on end? And the answer, quite likely, if it's an older person, may very well be no, especially if they've got no children of their own, and they rarely ever look into that aspect. Is there another dimension here that we can help these patients with, that might be outside the classic, here's a drug, or let's put you on a trial even. And that's sort of the priority for a lot of these doctors, because that is the constant 24/7 bombardment that they're receiving when you go to a lot of these conferences. They try to do some of the more palliative care, holistic aspects, but they're not very substantial. I mean, they're quite practically non-existent, actually. So
that's that's very interesting as well. Yeah,
it's interesting, and it's a shame, because it shows you, Katherine, that there's a lot to be learned as well from a patient and at their own experiences. And I think sometimes that isn't revered enough. And in fact, there was a big study done in the Journal of Clinical Oncology. I think it was in 2016. I remember sitting next to a clinician, and he said, listen to this plenary session speaker. This trial is amazing. They did a patient-reported outcomes, or PROs, and they showed that you could get a 5-month overall survival benefit just from filling in a proper patient questionnaire about the adverse events and toxicities they experience when on a therapy, and to look at that carefully and decide how they could best manage their symptoms, just symptom management, not about getting new treatments. That gave an overall survival advantage of 5 months. There is not a single cancer drug that has been approved in the last 10 to 20 years with an effect as good as a patient-reported outcome. In other words, the patient's own justification data trumps all those top big therapies that are costing hundreds of thousands of pounds.
That's really, really important. I mean,
That's huge.
It's crucial, isn't it? It's key.
Yeah.
Maybe that could be maybe we could wind up, but it's interesting your 3 T's, because from a naturopathic perspective, the 3 causes of disease are toxicity, deficiency, and stress, which do, sort of
Tie in,
coincide
really. Yeah, they do.
what you're saying. And
Yeah.
in homeopathy, we very much, it's a person-centered therapy. You're entirely and that's why it takes so long. Generally an appointment would be up to an hour, or certainly a first appointment, because you want to find out all about that particular person, what their likes and dislikes, all sorts of peculiar things, like what position do they sleep in at night, and what their favorite foods are, and what their hobbies are, all of those things. I think it feels like a much more natural way to approach somebody who's sick than to just do the tumor centered approach.
Yeah, I agree with you. And I think that, we sometimes do have to have surgery for certain things. Of course we do. So allopathic medicine has a role to play. We're not suggesting that it's all bad, but the focus has been far too much on a customer for life from cradle to grave attitude among the large big players that have billions, if not trillions of money to exert their prowess, shall we say. And there's going to be lots of other things we talk about: censorship and corruption, 2 important C's. And like you say, Katherine, we've got this event that we're advertising that's taking place in 3 weeks' time in London in April the 11th, which is Thursday. It's from 4:45 in the evening until 9:30 p.m. If anyone's available, it's for £20 tickets or £25 full price. We really strongly encourage you to come to this event. But we've tried to co-organise this event, haven't we, Katherine? We've found that there are certain, even just words that we can't use, or that somehow manage to get us booted off certain platforms just from having free speech. We haven't said anything, I don't think, in our chat today that's in any way overly controversial. I mean, the topic is interesting, but we haven't reverted to any, should we say, disparaging language particularly. Yet here we are having to, carefully choose the words that literally, we're monitored on the English language to the point where if you don't use certain words, or you do, you're either in the good books or in the bad books with
Yes,
big government, big tech, big pharma.
that's right. We have to get creative
Yeah.
and find other ways to say things. Even our flyer, we had to think very carefully about the words that we were going to use, didn't we?
That's right, we did. So we tried to come up with something that was also, more all-encompassing in a sense, but at the same time, just intriguing people, I think, to get them to think, oh, sort of, what's our society all about? Is it restricted or is it free? It's up to us. Let's debate this in London. As I say, here's the flyer in 3 weeks' time.
Fantastic.
So, yeah.
Thank you.
Good
Thank you so
notes, I
much,
think.
Lisa. It's
Yeah,
been really good to
thanks
speak
so
to you.
much. Lovely. Thanks, Katherine. Lovely to speak to you too.